Good afternoon, ma'am.
So, yeah, just tell me about yourself.
Uh, my name is Sumit, and I have done some around. I have 5 year of experience in coding, but specifically in IPDRG, I have 2 year of experience. From last 2 year, I am doing IPDRG coding, and I have done a certification of CPC only. So as of yet, I have not completed my CIC or CCS, but maybe in future I will do.
Okay, perfect. So, you're planning for inpatient coding certification.
Yeah,
Okay. May I know your qualification background?
I have done graduation from mathematics. I have done BSc in mathematics, and from even last 10 years, I am into this RCM sector. My, initially, I am in AR. Then I moved to in billing. Then I moved to in coding.
Okay,
So
perfect.
I have experience of 10 years in this RCM sector.
Perfect. Perfect. So, why you choose medical coding means you already having established experience into billing and AR. So, then why you choose to come and join in medical coding?
Because coding have a better opportunity in terms of their personal growth, and even uh, there are a lot of things in which we learn in terms of getting it's very demanding. Basically, coding is very demanding as compared to billing and this AR.
Okay.
So that's why I think to switch into coding, and even we know that it's also paid more. So this is the main reason.
Okay. So means you wants to learn more new and new things, and
Hmm.
also you wants to keep earning also.
Yeah.
Yes, perfect. So Sumit, just come to the technical points.
Hmm.
As you mentioned that you having just 2 years of experience in IPDRG.
IPDRG,
So
yes.
may I know which software you manage, means in which software you worked for EHR and coding.
It's a 3M software, and in via using of 3M software, we do PCS coding as well as ICDs.
Okay.
So 3M is the only software we use to do IPDRG coding.
And what EHR software you use to work?
EHR, it's Epic.
Okay, perfect.
Mhm.
So you worked in the Epic software.
Yeah.
Okay. So may I know what kind of specialty you were managing while doing the inpatient DRG coding?
Specialty is a multi-specialty, but there are three, four specialty for which we do IPDRG coding. It's spine neurosurgery as well as a cardiac specialty.
Okay.
Uh, yeah, there's only two in which we do IPDRG.
Okay. Um, could you please explain what is UHDDS guidelines?
UHDDS basically is for inpatient stays, and it's responsible for payment system for inpatient basically, because there is a different for outpatient there is a different body, and for inpatient it's a USDDS. We follow USDDS.
Okay. And what is the full
Mhm.
form of UHDDS?
Full form of USDDS is unified Unified Health uh, Data Set.
Okay. You just recall your memory means
Mhm.
exactly.
UH, yeah, UHDDS. Uh, Data set is it's for last abbreviation uniform UH Uniform standard of health. Yes.
Okay, fine. Let's move to the next question. Uh,
Okay.
Give me brief about the selection of primary diagnosis or
Yeah.
principal diagnosis.
Okay. Yeah. We choose basically we avoid symptoms as a principal diagnosis. But for admitting diagnosis, we can use we have to use symptoms. But for primary uh, principal diagnosis, we used to see, and we have to look for definitive diagnosis. And if we
Okay.
if and even we see what are basically, if we have differential diagnosis, we have to choose which have a more weightage. If we
Okay.
if for both they have similar workup, then we see the priority by choosing by seeing DRG this weightage, which have more high weightage.
Okay. Perfect.
Mhm.
Could you please brief about the CC and MCC condition with examples?
Comorbid CC is for which patient already have along with them. So like patient have a diagnose sorry this diabetes, patient have some heart disease. So this acted as a CC condition.
These are the example. What exactly meaning of CC and MCC?
Okay, it's a comorbid diseases. It means whoever have a like less who have a chances of getting more severe. So these are comorbid conditions which also patient have along with them, and from a very long time, patient are suffering from these conditions, basically chronic conditions. But MCC are major comorbid conditions, which is more severe than uh, CC, more like more threat to life. So this is the only
Okay.
key difference between them, CC and MCC.
CC basically it is impacting on the health status of the patient, and
Yeah,
MCC it is impacting on the life of the patient. It is a life threatening conditions. Okay, so this is a major difference.
yeah.
Okay,
And
so
even this MCC also make a very good amount of change in DRG value.
perfect. So CC and MCC both impacting, or only MCC impacting on DRG.
We basically give priority to MCC when we find MCC is the chart. If there are many CCs also, then it is only just for reporting purpose, but it does not make any changes in DRG values.
Okay, and suppose if we do have only CC,
Mhm.
does it impacting on DRG value?
Yeah, CC and MCCs are both impacting, but a major impact is bring by MCCs. But if we don't have any MCC, then we have to build with CC also, that because it's also impacting the DRG value overall number.
Okay, and what other factors can impact on DRG?
As we talk about MCC, as we talk about CC, the third is the procedure. PCS code will also bring a huge change in DRG number.
Perfect. And what other factors?
These are only three factors which bring changes in DRG numbers.
Okay, okay, let's move to.
MCCCC and this PCS. Or sorry, whichever if we choose uh, principal diagnosis, it's also bring changes.
Mhm.
Yeah. It means CC, MCCs, and principal diagnosis. as well as PCS code will bring a huge change in DRG number. It's also impacting our overall DRG number in a claim.
Okay. What about the length of stay and age factor? Does it impacting on DRG?
Length of stay, uh, length of stay does not make any change in DRG.
And age, gender, does it impacting?
No.
Are you sure?
Uh, Basically, for like for if we consider, if we are giving service to newborn, it automatically change any if it automatically bring severity, it's automatically bring sensitivity in the claim. So that's why, yeah, it is in by default the DRG number is automatically uh, calculated, automatically have given to patient age. So yeah, for some extent, yeah, it's bring changes, but not majorly. Yeah, newborn cases have a different severity.
Okay. Okay. So, Sumit, we came into 2025
Mhm.
and we know that ICD-10-CM is getting update on November 1st every year. So, could you please give me some updates of ICD-10-CM?
ICD 10 cm have some around 200 204 ICD 10 cm. So basically, ICDs, there are some changes, but specifically, it's related to the status code, Z codes. It's not just, it's not, there's only two, three changes, not more than changes. And it basically is for Z codes only.
Sure.
But yeah, but for CPTs, there are huge changes. 204 CPTs get changed. It's revised,
Mm-hmm.
and 18 or 54 maybe is added.
Okay.
Mhm. That's it. I know about the changes.
Okay. So you need to make sure that you will be keeping update everything about the ICD-10-CM and CPT.
Okay.
Okay. Let's move to the next questions.
Okay.
If the patient came with the fever and physician has admitted to the hospital, and during the admission, physician found that patient is suffering with respiratory disorders, and after diagnose the final principal diagnosis, physician found that the patient is having respiratory failure and sepsis, then how you will be coding this scenario?
Okay. So you said patient is come for,
Fever.
okay. So we just need to see whether sepsis, we have to like query in this case, because we need to know that sepsis is present on the first day or not, because
Okay.
it's make a huge change, because sepsis is act as a MCC condition. So if we know that it is a present on admission, then it will be the principal.
Okay. Otherwise, you think that respiratory failure will be the principal diagnosis, right?
Yes.
Okay. So either one we can report as a principal diagnosis, right?
Either one, actually, if we find that there is because of sepsis only this respiratory condition is rises, then a condition will be the principal, then respiratory will be the secondary J code.
Okay, perfect. And suppose during the admission, physician has performed CPAP
Okay.
for 24 hours. So,
Mm-hmm.
Miss, how you will report the principal diagnosis?
CPAP. Could you repeat that? If
If the
we.
physician performs CPAP for 24 hours,
Mm-hmm.
respiratory failure. So, would
Mm-hmm.
you think that the respiratory failure will be the primary principal diagnosis, or sepsis will be the principal diagnosis? Which will,
Actually, you are saying that it's the claim also have this patient also have sepsis in
yes,
this scenario.
the same
Okay.
patient who came with the fever, and
Mm-hmm.
during the hospital admission, physician
Okay.
performed the respiratory failure and sepsis. And for
Mm-hmm.
respiratory failure, physician performed CPAP for the 24 hours. Then how
Okay.
you report the principal diagnosis?
Okay. Yeah. In that case, also okay. CPAP. So it's a mechanical ventilation, right?
Right.
So mechanical ventilation, it's also act because uh, it's also act as a MCC condition.
Mm-hmm.
So in that case, we don't raise any query because we also have. It means we have a MCC now. So what we do, the procedure a PCS code is added, and we will, yeah, we will code it MCC. Oh, sorry, we will code CPAP.
Hmm. Okay. Okay. No problem. So let's move to the next question.
Okay.
Okay. So tell me characteristics of PCS procedure codes.
Yeah, it's a 7 characters.
Okay.
First for sections,
Mm-hmm.
second for body system, third for root operation, then fourth for body part, and
Mm-hmm.
fifth for device, sixth for
Okay.
sorry six approach, then device.
Okay.
Mhm.
And how many route of operations are there in PCS?
Root operation are 31.
Okay. Could you please give me at least two to three route of operation uh, examples?
2 to 3 examples. Basically, resection,
Mm-hmm.
detachment, destruction, extraction.
Okay. So what is the difference between restriction and occlusion?
Oh, restriction and occlusion. Uh, Basically, restriction is these are for tubular device, tubular for like the tubular the organs
Okay.
restrictions. Hmm.
Mm-hmm.
And restriction basically is when it was get restriction, it was get restricted. Like if we say that um, there are many procedures like restriction. I would say that example is laparoscopic gastrophageal fundoplication. So in this basically restriction, like and you heard about aneurysm. Okay, in
Mm-hmm.
this
Yes.
uh, okay, aneurysm, there are like by aneurysm we have to we sometimes we will use to restrict, and sometimes we will use for uh, restriction as well as occlusion. Occlusion is basically for completely blockage, for completely obstruction. If we want to restrict some blood flow uh, in some part, so we will use root operation restriction. And if we want to completely cut off and want to completely close that tubular part, we will use occlusion. This is the two difference.
Okay.
Mhm.
Okay. So when the patient came with the poisoning and
Mhm.
uh, during the admission, patients also having the sepsis symptoms. So according to ICD, how you will report the principal diagnosis?
You said poisoning. So in
Right.
that case, poisoning will be the uh, mm, mm, poisoning will be the principal.
Okay.
Then
Fine.
secondary will be the sepsis.
Okay. Fine. Okay. Let's move to the next question.
Okay.
Uh, could you please tell me the clinical indicator of respiratory failure?
Respiratory failure, clinical indicators. Basically, clinical indicators are the indicators in which basically we see in our records, which is late because in differential diagnosis we don't find any diagnosis, and if we see some kind of symptoms in our note, we can query, we can ask provider, is there any diagnosis which you missed? So because it act as a MCC or maybe CC, so this is the only
No, no,
reason
I'm just
we.
simply asking about the clinical indicators.
Mhm. Okay. So clinical indicators, you are asking for respiratory failures. So
Right.
yeah, so respiratory failure, if we see there is a if the patient is shortness of breath, because it's or yeah, shortness of breath, even if we see mm, um, respiratory failure, yeah, shortness of breath, and patient have difficulty there is a if there are some x-rays and CT scan of lungs, and abnormal yeah, there are three four common scenarios, I would say, that we see in respiratory failures. Like patient have a, like I told you that many times, that patient have difficulty in breathing, as well as we see that CT scan and X-ray is performed, and yeah, that's it.
Okay. Okay. Let's move to the next question. If
Okay.
patient came with the pneumonia
Mm.
and during the hospital stay, the physician found that the pneumonia is a aspiration pneumonia.
Okay.
How you will report, means whether you report only pneumonia or you will report the aspiration pneumonia.
Uh, Aspiration pneumonia is the specific, huh?
Yes.
So we will go aspiration pneumonia.
Perfect.
Mm.
Okay. Give me brief about the fusion because you mentioned that you worked in the orthopedics and
Mm-hmm.
cardiology. So
Okay.
how the fusion procedure will performed and
Okay.
how you for the
Mm.
PCS.
Okay, fusion basically, it's we are fusing the cartilages. Okay, like in spine, we are fusing, so it means we are making it immobile. So it's basically in a spine. If we fuse, uh, so if we there are three sections: cervical, lumbar, and thoracic. So if we see, if in cervical section they have performed fusion, then we will see how many. section are there, how many like there are seven C section or seven disc over there. So we will see how many disc they perform discectomy, because discectomy also it's a different we have to code along with the fusion, and we need to see if there are if grafting is used. If the grafting material is synthetic, it also bring changes. And if we see the grafting is autologous, it's also it does not make any changes in the code. But yeah, it's also we if it's also make changes in a number only, that PCS number, it's get changed. Because autologous, we don't have to code extra we don't have to code in autologous, because in autologous basically from your sternum, their incision is given, and the sternum part is removed as a and it is used as a autograft. So we don't code specifically different code from the PCS. It's inclusive in that PCS code of fusion of spine, as well as a laminectomy also performed in the same C-section cervical region. If laminectomy is performed or foraminectomy is performed, then we don't code, because it's also inclusive under the same fusion area. So we only code distinctly when we see discectomy is done.
Okay, perfect. So, means the next procedure is CABG. So, you just
Okay.
give me about the CABG. How is the guideline?
CABG, it's a coronary artery bypass graft. Basically, when there is a blockage in the heart muscles, basically the veins which unable to provide supply oxygenated blood to the muscle of the heart. CABG procedure is performed. So in that case, we just there are two, three different things which make changes in DRG. First of all, we need to see how many graft is used, and uh, there from the origin, from which origin it is. Basically, aorta it is, from descending part it is, from where the base region of the vein is connected. Um, yeah,
Okay,
yeah, two scenarios is enough. Uh,
okay, fine.
mm.
Let me move to the other questions.
Yeah, one more thing in CABG, ma'am, we need to see from where this graft is obtained. It's also make a big change, because
Perfect.
yeah, from only if the procedure is performed and they choose from Rima Lima, then we need to code additional code. It's inclusive in that.
Okay.
Mm.
If the patient came due to COVID,
Mhm.
and COVID is due to the atrial fibrillation, okay, and the
Could you
physician
repeat that?
performs procedure. Sorry,
Could you repeat that? Patient come
if
at
if
COVID.
patient came with the COVID,
Okay.
confirmed COVID
Uh-huh.
due to atrial fibrillation, okay,
COVID due to atrial fibrillation.
yes, and physician performed the procedure for atrial fibrillation, and both condition were at the admission. Then what will be the principal diagnosis? How you will report the sequencing?
Hmm. So, in that case, you said the patient is COVID positive, and the patient comes to hospital having some chest arterial fibrillation. Patient come
Yes.
and
COVID due to atrial fibrillation.
COVID due to atrial fibrillation. Okay.
And physician has performed the procedure for
Hmm.
atrial fibrillation.
Okay.
And both diagnoses were at the time of admission.
Okay. Yeah, in this case, arterial fibrillation. We will try to find the code. Is there any combination code or not? So if we find that combination code, we will code it as a principal and as well as admitting. Is this your question? Is what will be
No,
code?
my question: what will be the principal diagnosis here?
Yeah, principal. I told that if there is a combination code, we will uh, we will uh, uh, we will give a combination code as a principal, and if we don't have a principal, then yeah, U07 have a crown, so that's why we will choose principal as a U07.1 and secondary arterial fibrillation.
Okay, Sumi. So now we will wind up the interview.
Okay.
So uh, I will give feedback after the interview.
Okay,
So
sure.
so thank you so much for your time
Okay,
and
ma'am.
best of luck.
Thank
Thank
you.
you.
Okay, bye bye.
Bye.